Is there any question from the audience that needs to be addressed? Because now we'll be moving on to complications of refractive surgery, both lens-based and laser-based. So is there anything for the routine procedures that we need to elaborate before that? Okay, so I would be talking about lens-based refractive surgery complications as well as laser-based. So now laser-based in itself, because there are different types of procedures, can be flap dependent or they can be the excimer laser dependent. And flap again is further divided into whether you're taking a flap using a microkeratome or whether you're taking a flap using the femtosecond laser. So each aspect has its own complications, or whether the excimer laser by itself produces any. So all these are the intraoperative factors. Then coming to the post-operative, you can have displacements of the flap, you can have an epithelial ingrowth. So again, displacements can be early or late. So I'm not talking about the very minor complication of microstriae, which may be seen in some patients, especially when done by novice surgeons, that usually don't produce any sort of side effects. So is it possible? Yeah, okay. So which usually does not produce any side effects. Sometimes it may cause a minor amount of astigmatism. But it is because the smoothening of the flap is not complete in all directions that microstriae arise. So anyone who is doing refractive surgery for the first time, they may find that their amount of microstriae more. But more serious are the macrostriae that may happen as a result of flap displacement. And if it happens later, or if the flap has been displaced for a longer time, then epithelium starts growing over the bare stromal bed from where the flap has been displaced, and also forms a layer over the folds of the flap so that they become fixed. And now you have an extremely folded flap which is fixed and a layer of epithelium over the stroma. So when you're dealing with this, it is not impossible to deal with it. You can get very good results, but please remember that the epithelium needs to be removed in toto from both over the flap as well as the stroma. There should be no cells left around, and unless you remove the epithelium over the flap, you won't be able to straighten out the flap so that you don't have those undulations produced by the epithelium. And after straightening out that flap, after removing the epithelium, though there may be small striae in the Bowman's membrane, still the next day itself you'll see that you have a very smooth picture once the epithelium comes back. So this is one of the most important points of my session that I wanted to convey, especially regarding flap displacement. Now the second point was regarding, this more like a lecture class I guess. The second point was regarding epithelial ingrowth. So I have seen different types, most of them are minor and they are to the edge of the flap where you don't need to do anything. But suppose they proliferate into the center of the flap and produce any sort of visual distortions in the visual axis, then you need to relift the flap. Don't wait. Once it has entered or is very near the visual axis, please relift the flap, and the epithelium needs to be taken off both from the undersurface of the flap as well as from the stroma completely. So complete peeling needs to be done, and then you would put in an inhibitor of epithelial growth like a little bit of alcohol, or more often mitomycin C, so that there is no further growth from the edges of the flap. And that is how epithelial ingrowth is to be dealt with. So these are some of the late complications that you can have. Ectasia has already been dealt with by Dr. Sujit. Coming to implantable collamer lenses, initially the injection of the lens is what is hard for the novice surgeon. That is because the injection needs to be done very slowly. There are people who sometimes flip the lens, and that usually happens because the injection is done fast and you're not seeing whether the leading haptic is moving in the correct direction. So that is very important that the injection be done slowly, and up to 5/6 of the lens, even if it comes out, you will always be able to turn your cartridge in such a manner that you can inject it properly. The second part is that all the haptics need to be tucked inside. There are 4 haptics. This is a plate, haptic lens, and all of them need to be tucked inside. You cannot leave anything outside because sometimes the pupil gives a false view. If it's a large pupil, then it gives a false view. Yeah, please do. It is complications of laser refractive surgery. I just want to show some videos. That's all. The first one. The PowerPoint there. Yeah. So now this is another unique complication that I had mentioned. So this was a person like Sujit's minus 2.5, and I thought it was cakewalk. I took the flap. This is one of my very early cases. And you can see once the flap is taken, the laser starts falling. But unfortunately, you can see there was some scanner error because of which all the spots fell in the center and you see a deep pit over there. So this is very unusual, and though my laser was calibrated and maintained regularly, this happened. But the patient who had initial uncorrected visual acuity of 6/36 had a topography which showed extreme flattening in the center over there. And this is what happened by 1 month's time, when you can see that a coagulum filled up the gap and the keratocytes came in and they, bridged it with collagen. So you had a slight haze over there, and his vision, thank God, was 6/9. So that is a lesson I learned. Now this is what I had talked about, but I think we have already discussed this, so I won't be going through it again. This is what I meant when you're taking off. The epithelium has to be scraped both from the stromal bed and from over the flap. So this is the epithelium being scraped from over the flap. And this kind of epithelial ingrowth is usually innocuous. Now this is an image of one of the things we used to have before the femtosecond laser came in. So you can see that you have a dehisced flap over here because the drape was preventing a proper flap dissection from taking place. Now such a flap needs to be repositioned, and you can do a surface procedure here. But still a scar remains. Now these are some of the femtosecond complications where you can have various types of bubbles. You can have innocuous bubbles that hinder pupil tracking, sometimes like this, or you can have air in the anterior chamber, which again would hinder pupil tracking a bit. So you can see how air escapes from the trabecular meshwork sometimes. This usually I've seen with thin flaps. So at least 100 microns is a good recommendation for a femtosecond flap. Then suction loss is also another complication that may be faced. When you're doing a femto, you can see that the suction stops there, and then you need to take the patient out, maybe wait for some time before the bubbles clear, and then do again. So this was epithelial nest removal, which I think I explained verbally very well. So that is, can I have the other one? Yeah, that one.
You have to rush through because
yeah, I will do
the
that.
time is 3:55. We have to stop, so you have to go fast.
Okay. So this is when you are injecting the ICL. It has to be very slow so that the orientation is proper. Now, when you have an untucked haptic, you can see a distortion like this in a small pupil. So that will make you aware, and you can, tuck in the haptic. But in a large pupil, it seems regular, but both the haptics are out there, down there. So that is the point I wanted to make. Then iris disturbances while washing the fluid can happen. So if you have an iris prolapse like that, then the first thing you need to do is dilate the pupil while irrigating. That helps a lot. It creates a channel so that you can push the visco out in a very harmless manner. So this is a Ured-Zavalia syndrome I had following ICL implantation, where the IOP was raised, the pupil was static, and even after 1 month, the pupil only recovered to that level. So overinflation of the anterior chamber can sometimes lead to that. This happens with some keratoplasty lamellar procedures also. Now rotation of the ICL usually never happens spontaneously. It may be post-traumatic, or initially you might not have placed the ICL well, where it needs to be re-rotated. So high vaulting ICLs are dangerous because they may induce glaucoma, a lot of pigment loss, wherein they need to be explanted. Then cataracts, we can do it with or without explantation of the ICL. And of course, retinal detachments, the chances are around 0.35 to 1.5%. Again, the ICL may or may not be retained. So, can I ask the chair's permission for 1 minute of... This is just to briefly describe one or two points about presbyopia management.